Well, thank you for being here, and thank you for asking me to be here to speak at this conference about my experiences and to tell you a bit about Soberistas and why it's important. I believe it's very important in the conversation about alcohol treatment and society's perspective really on people who've got an alcohol problem or what even constitutes an alcohol problem. So here is a horrible photograph of me many years ago when I was a drinker. I stopped drinking in 2012 and I'll tell you a little bit more about why that happened and what happened afterwards in a while. But needless to say, before I stopped drinking, I was a very enthusiastic binge drinker. I wouldn't have called myself an alcoholic, and for reasons I will go into in a minute. I think I was a very enthusiastic party animal. Did grow up in the ladette culture of the 1990s. I was born in 1975, so when I was 20, was sort of right in the middle of the ladette culture. And I was very at home in my local pub, drinking pints of Boddingtons, smoking, playing pool, and not being at university very much. And when I got a little bit older, I swapped the pints for wine and continued with my enthusiastic love of alcohol. So I did have lots of problems, got into lots of kind of scrapes when I was drunk and drinking. But again, just to reiterate, that word alcoholic was so kind of extreme. It's not something that I would ever have classed myself as. To give you an idea of how much I was drinking, it was probably kind of a bottle of wine some nights no alcohol. When I went out at the weekends, quite a lot more than that. I did tend to black out quite a lot. I often did things that I was really mortified about the next day, couldn't remember getting home, was always the one that was a bit of a liability on a night out. Friends would put me in a taxi and I'd have to get home in a bit of a state. And that kind of continued all the way through my 20s, but it was against a backdrop of binge drinking, so it was very normalised, and I didn't really think there was much wrong with it, apart from on the odd occasion. Quite a different landscape now, I think. I'm 47 now, and the conversations and the stories, the features in the media that we see about the risks of binge drinking are quite a lot more prevalent than they were back in the mid-90s, when people still very much believed that red wine was really good for you, even if it was 3 bottles of red wine on a Saturday night. So, I wasn't an alcoholic, but what is an alcoholic? I did have a little Google of what is an alcoholic when I was writing my notes for this speech, and a few of the things that came up immediately were a chronic disease in which a person craves drinks that contain alcohol. I don't think I ever thought I had a chronic disease when I was drinking a bottle of Chardonnay on a Friday night, watching a bit of TV. Unwanted physical or mental effects from drinking. Well, that's kind of everybody who's ever had a hangover, so that's not particularly helpful. Another definition was that it's a disease that progresses over the course of time. Well, mine didn't. I started drinking when I was 13, binge drank the very first time I drank alcohol, and continued to drink in exactly the same way until I was 35 when I stopped. So there wasn't any progression there. Another definition was that alcoholism is defined by heavy drinking, which is more than 4 drinks on any one day, or more than 14 drinks in a week. Well, that's kind of everybody I know, apart from me and the people who are on Soberistas, the website. So that, again, isn't very helpful. And when I was looking at these definitions, it did kind of make me realise why we've got such a problem with defining in our own minds whether we've got a problem with alcohol or not, because nobody really knows what an alcoholic is, or if they do, it's different to what the next person thinks it is. So, yes, here's this lovely picture of this poor man who I always put him on the whenever I'm doing a talk, the slides, but it is a kind of stereotypical visual representation we've all got of an alcoholic, I think. That kind of park bench drinker, somebody who's drinking bottles out of a brown paper bag, somebody who's life has been completely ruined by alcohol, and that just wasn't me at all. So I was running half marathons when I was drinking. I did a fast-track law degree when I was drinking. I was never in trouble with the police or social services, never had a driving conviction because of alcohol. Very high functioning, just like to drink. And that's most people, I think, certainly in the 90s and the noughties who I knew, of all different walks of life, would have fallen into that category. But alcohol took a little bit of a turn for the worse for me when I was in my late 20s and I got divorced, and I did start to rely on alcohol a little bit more at that time as a way of self-medicating. So I would drink a bottle of wine most nights after my daughter had gone to bed, and unbeknownst to me, I was exacerbating my depression, underlying anxiety, by drinking as much as that, but I didn't realise that that was part of it. Went to the doctors lots of times for antidepressants, was never asked how much I was drinking, even if I did drink, which is quite staggering now, really, when I think back to that time, because I was suffering a lot from the mental health consequences of drinking. So after drinking quite heavily for a few years to self-medicate my way through my divorce, I set up this website, Soberistas. And the reason I set it up was because I very much realised there was a big gap for people like me in terms of the help that was available. I would not have called myself an alcoholic. I really, really didn't want to go to AA or Smart Recovery and potentially bump into somebody that I knew, and I didn't want to call myself an alcoholic, and I was a single parent who wouldn't have been able to go to 90 meetings in 90 days, and it all felt very extreme for my kind of drinking. So I set up this website called Soberistas, which is basically a social network website for people with a problematic relationship with alcohol. And Soberistas is just really a place where you can blog, speak in forums, connect with other people who are in a similar place to you, and won't judge you. And it acts as a little bit of a confessional, so it's a really nice place to kind of talk freely about your relationship with alcohol without feeling as if you're being stigmatised or judged in any way. And Soberistas, since its launch in 2012, has now got 80,000 registered members all over the world, and is still a very lovely, very positive, very busy place, full of people who are all supporting one another in their efforts to stop drinking. So why do people end up in this place where they are drinking too much alcohol? And how do you work out that you are drinking too much alcohol when we're surrounded by this society that sort of endorses alcohol and glamorises it? I've listed a few things on this slide here. These are the things anecdotally that come up on Soberistas all the time. So I am a lay person. I'm not a scientist at all, and these are not things that I've kind of got out of any research, but stories that I've read in blogs, thousands and thousands of people on Soberistas over the years who've blogged about their experiences and why they drink alcohol. And 90% of our members are women. Most are middle class, and most are between the ages of 40 and 65. And there's a very common pattern of drinking. There's a very common sort of theme amongst those people on Soberistas and why they started drinking. And these things are all things that come up all the time. So women, I think, on Soberistas, a lot of them feel a huge amount of shame and embarrassment, and won't ever go to their doctor or ask for help in a face-to-face context because they're very worried about being judged, and feel very ashamed about not being able to control their drinking. That's obviously something that I felt, which is why I set Soberistas up. One of the reasons why, because it's completely anonymous, so helps people protect their protects, you know, their kind of anonymity and not worry about having to get the social services involved or having their job prospects affected or any other reasons that might keep them from talking openly about it. Alcohol's so cheap and available and accessible. COVID, we saw a huge increase in people drinking problematically during COVID. Lots of people who already had an alcohol problem, but suddenly the kind of restrictions that were there before, going to work, doing the school run, all got removed, and it just became normal to start drinking in the afternoon. And then that continued reinforcement of the normalisation of excessive drinking. So one of my bugbears, the greeting cards, you know, the happy birthday cards, and just the constant trivialisation and reinforcement of how normal it is to binge drink in England, the UK. It's just everywhere. And when you've got a problem with alcohol and you're looking for reassurance that it's okay to drink the amount that you're drinking, those sorts of reference points are everywhere and really unhelpful. So there's a few reasons why people on Soberistas drink and stay drinking in secret. So why does it matter if you drink too much anyway? So again, you know, we can always look for positive references about alcohol and how it's a really kind of essential part of life, and how it adds a little bit of, it's a treat at the end of the working week or at the end of the working day. It's essential for celebrating, it's essential at Christmas, all of those things. But how do you know when it really is a problem, and what are the signs that I recognise on Soberistas and that I recognised in myself that made me realise that alcohol just wasn't something I wanted in my life anymore? I basically felt like I'd lost control over alcohol. So when I drank, even if I set out to drink only 2 or 3 glasses of wine in the evening, I'd quite often just drink a lot more. I'd have blackouts. I was overly concerned about how much alcohol was available. I would always look at what other people had in their glass and whether it was going to be, whether they might judge me if I went to the bar and got another drink, if it might look like I was drinking too much. I overthought it, and it was always kind of at the forefront of my mind. And I think when I look back now, that was probably the biggest telltale sign. People who don't have a problem with alcohol don't really think about alcohol. It doesn't really enter their heads. People who do have a problem with alcohol obsess about alcohol. It's on your mind a lot, and it was on my mind a lot. And in the end, the thing that made me stop drinking was waking up in this hospital in Sheffield, where I live, after a particularly heavy binge drinking night. And again, kind of the depression and anxiety that I was feeling at the time contributed to my last night of drinking. So I did a law degree, couldn't get a training contract, was feeling very sorry for myself. And because alcohol had always been my go-to medicine, if you like, my go-to kind of self-medication when I was feeling low, I really went for it one night and drank 3 bottles of wine on my own, which was a lot even for me. Passed out on the pavement outside my house, and then woke up here in Sheffield's Northern General Hospital and couldn't remember anything about getting there. So at the age of 35, the penny finally dropped after 22 years of drinking very heavily, binge drinking on a regular basis. The penny dropped that I would always have a problematic relationship with alcohol, and that if I wanted to have a life that was not defined by alcohol, I had to get rid of it completely. And so I did. So I stopped drinking then. It was very easy to stop drinking in terms of the physical withdrawals. I didn't have any physical withdrawals at all. But psychologically and emotionally, it was really, really hard. And the thing that I realised the most, I think, at that point was just how much we are a society that loves drinking. So it was just everywhere. I felt triggered everywhere. Supermarket, Christmas, birthdays, weddings, sunny days, holidays. I mean, literally everything. Every kind of point in my life was in some way related to alcohol for quite a long time. But eventually that passed and life became much better. This is me and my daughter, who's now 24. That was just after about a year after I stopped drinking. And life, I was very surprised that it had never occurred to me to not drink before I stopped drinking. I grew up believing you had to drink as an adult. And it honestly had never entered my head that you could be happy and not drink. But I discovered that this was the case. So without alcohol, my panic attacks stopped, my depression pretty much went away, my anxiety just almost disappeared completely. I threw myself into running, which I'd always done anyway, but always with a bit of a hangover. It wasn't great. And just my mood was completely different, and I realised that actually I wasn't a manic depressive, which I'd always thought I was. I was just somebody who didn't drink alcohol anymore, and suddenly I was quite happy. So life became really good, and that message was something that I put into Soberistas. It's not about kind of gritting your teeth and getting through every day wishing you could drink, but actually celebrating the positives, the huge positives that come with not drinking alcohol. Mainly, for me, mental health. It was difficult to stay positive and to really feel empowered about being a non-drinker in the face of lots of kind of pity and people feeling sorry for me because I could no longer drink. And whereas people kind of feel great, you know, excitement when somebody stops smoking, when you stop drinking, you do tend to get a bit of an arm around the shoulders and people sort of look at you a bit, well, how are you finding it? That must be really hard, and are you okay? And it kind of really amazed me that people never gave themselves the chance to even try not drinking, because it had made such a massive difference to my life and my levels of happiness. And I felt a bit stunned at how much people felt sorry for me when I was so happy. But anyway, that's the message behind Soberistas. So people who join Soberistas, although we recognise it's very difficult to let go of alcohol, especially if you've used it as a crutch in your life, it is something to celebrate, it is something to feel excited about, and it's something to be really positive about, because life is so much better without it. And then I just included this quote from one of my favourite films, which is Goodfellas. Your murderers come with smiles. They come as your friends, the people who've cared for you all of your life, and they always seem to come at a time that you're at your weakest and most in need of their help. And this quote really kind of summarises the experience of alcohol for me, once upon a time, and the people on Soberistas. So trying to stop drinking often is something that we have to do when we're at our lowest ebb, and something that we have to do when we've got no emotional resilience, no kind of toolkit, no way of coping with life without that crutch, because most people who I come into contact with who drink have been doing so since they were a teenager, so they've never really learnt the skills of dealing with life without it. And it's really scary kind of letting go of that comfort blanket, and alcohol feels very much like a comfort blanket. Lots of people think that they're not going to be able to cope with life without it. But Soberistas, because it's a mutual aid website, people are able to talk and connect with people who are further down the line to them, so they can see the proof that if I don't have it for 6 months, I might end up being like these people. They've got a little bit of hope that that what they think about alcohol is not actually true, and that turns out to be the case. So we've now got people who are celebrating 10 years of sobriety, who've been on Soberistas since the very start, which is amazing. And a lot of those people stay on the website and help support and encourage new people who come on. And we are just in the process of building our app, so hoping to take it to the next kind of level and making it much better than it is, and reaching more people than we have been able to do so far. But yes, so that's my story and what led me to set up Soberistas. If you want to look at Soberistas, it's just soberistas.com. And yes, thank you very much for listening to my story.
Thank you so much, Lucy. So if you have a question for Lucy, keep it in mind, because we're going to take questions after both talks. So keep it in mind so you're ready to ask it when Julia has finished. So thank you, Lucy, for sharing so much personal detail, and I think everyone here would probably have found that very engaging indeed, so thank you. What I want to do now is just introduce Julia Sinclair again. So Julia is a Professor of Addiction Psychiatry in Southampton. has been working in the area of research in alcohol use disorders and their comorbidities for about 20 years, and runs the alcohol care team with a multidisciplinary colleagues at Southampton General Hospital clinically. So, Julia, thank you very much for speaking today.
Thank you, David, and thank you to the BAP for putting this together, and to Lucy for kind of setting us up so well. And I first heard about Lucy actually on D level of Southampton General Hospital, where I was sat in my clinic, and one of my patients came in and said, I just read this amazing article in the paper about this website, and I've been on it, and for once there is something there that actually meets my needs. And I think, you know, there are many other now, you know, organisations other than Soberistas, but actually it's about that sense of kind of the expansion of some of the traditional models. And what I want to do now is to kind of build very much on what Lucy has already talked about, and just this complex idea about alcohol in our society, some of the models and diagnoses beyond Google of alcohol dependence, alcohol use disorder, and thinking a little bit about prevalence and harm and how we actually implement those kind of evidence-based interventions. So alcohol, who says how much is too much? And what I want to do is to kind of think about a framework which I use in our research at the moment on alcohol care teams. So I think about it at sort of three broad interwoven levels, really. Oh, sorry, it's gone back. And that is the individual, which is the kind of the micro level, where we have their stories, their experiences, their priorities, the values, and this is what I'd call a kind of micro level. But that person and their immediate circle of concern are part of and very much influenced by social norms, as Lucy was talking about. And that's what I suppose would be called the macro level. And by that I mean society, laws, accepted norms, government policy, those kinds of things. And running between these two levels are what Foucault would call the dispositif, or the apparatus of power. But you didn't think you'd hear Foucault in a BAP lecture. But anyway, the apparatus of power. And those are the various institutional and administrative mechanisms, as well as knowledge structures, that enhance and maintain the exercise of power or social norms. And this is kind of like the meso level, that middle layer. And it includes a range of entities, including the press, social media, healthcare systems, guidance like NICE, the BAP guidance. These are all embedded and often operationalize the socially accepted norms. However, at the same time, these entities, organizations, are populated by people who are individuals with their own stories, experiences, priorities, and values, and who can also affect both the meso and macro level. And so this complex system continues. And like all complex systems, it's really hard to predict when and how there's going to be a seismic shift at the macro level, like, say, we saw with the move to ban smoking in public. That just suddenly happened, didn't it? And however, all of these narratives and the culture at all of these different levels often have very long memories. Think like every men's World Cup final ever since 1966. Every time that happens, the narratives come out, don't they? We don't need to remind ourselves of them, but they are there. And so this can make it really hard to make some of the changes required. So I just want to share with you one of these, really, which is Benjamin Rush. He was a physician in the United States of America, as you can see, back in the 1700s. He was not a prohibitionist, but he wanted to actually support the temperance movement. He didn't think banning alcohol was going to be a helpful thing to do. And so what he did is he divided alcohol use into what was considered temperate and what was intemperate. So if we think about the temperate, you know, this is as you can see up there, you know, water, wine, cider, the small beers, the things that were probably safer to drink than water. And as you can see, the impact of those things was health and wealth and cheerfulness and strength and nutrition. So what our drinks industry in the modern age would call responsible drinking. Yeah. Whereas Further down, as the alcohol got stronger and the frequency got kind of more kind of intense, what you then started to have was he describes both the diseases but also the vices that were there in terms of that. And if you look at his diseases, actually what you can see are really good descriptions of alcohol withdrawal. So we have, puking and tremors of the hand in the morning, bloatedness, inflamed eyes, red nose and face, sore and swelled legs, jaundice, pains in the limbs and a burning of the palms of the hands and soles of the feet, peripheral neuropathy, described there in 1790. So really, really, this man knew what he was talking about. He knew his subject. But also in there, you can see those sort of stigmatizing attitudes that remain so prevalent towards people still today. The kind of fraud, anarchy, hatred of just government. Be nice if you could find a just government, wouldn't it? But anyway, all of these things which then have the punishments that come along with it. So if we fast forward 230 years, it's what are the lenses that we now use to examine this complex phenomenon, which is the trajectory into harmful alcohol use and beyond. And so how do we synthesize the complexity of the relationship between history, society, and the individual into kind of simpler models that have some face validity and hopefully some underpinning of evidence? And we all know any model is a simplistic map. It's at best is going to give us a partial explanation. And these are some of just the examples of models and peoples whose ideas have had traction over the last 50 years. And they essentially divide into the three main categories. You've got social, so you've got Alexander and his Rat Park work back in 1978, the growing body about adverse childhood experiences, the links with social inequalities, educational failure, etc., etc. When we think about some of the psychological models, there's all the massive body of work on personality factors, impulsivity, compulsivity, sensation seeking, all of the learning theories, you've got Pavlov, Skinner, Bandura, to name just three, all of which have this impact into how people may ultimately develop a problem with alcohol. The sense that it is the management of psychological distress, as Lucy was talking about, the expectancies, what do we think is going to happen to us when we drink alcohol, which will have an impact. And then you've also got all of the biological ones, starting with Jelinek probably in the 1960s, and then the work of Nora Volkov, Koob, our own Trevor Robbins, the gene-environment interaction, the kind of polymorphisms and the impact on psychopharmacology, etc., etc., etc. And most of these, I think most of us would now agree that no one of these ideas can exclusively be used to explain the myriad different ways that people may lose control of their alcohol consumption. They are just lenses through which we try and view the phenomena and explain it. And another way of trying to get to grips with this is really how diagnostic systems have evolved. And many of you in the room will be aware of ICD and DSM, but for those who don't, essentially ICD, the International Classification of Diseases, is the apparatus of the World Health Organization. That is where it fits. It gives a way of kind of conceptualize diseases and death, actually. Whereas the Diagnostic Statistical Manual, the DSM, is the US version, which started life and still continues in much of its work, really as a way to ensure billing happens properly for the correct treatment of the correct disease. And those differences are really, really important. And what they have in common, though, is it's a much more clinical approach, which is somewhat different from those theories that I just showed you in the last slide. So like with other mental disorders, alcohol diagnoses have evolved from observing and categorizing clusters of behaviors and mental and physical signs, and then trying to work back to explain how and why they arose, just like Benjamin Rush did back in 1790. And so if we think about the last century, we begin with AA, Alcoholics Anonymous. It was started in 1935 by one doctor, and I think the other man was a solicitor, who met each other, recognized in each other a pattern of behaviors and consequences that really resonated with them. And so AA was born. They embraced it as a disease model. And this then had a significant consequence as quite a unitary concept for much of the earlier half of the last century. And before 1970s, there was this just concept of alcoholism, which was excessive consumption a compulsion to drink, the denial of problems, and that's very much still embedded within part of the AA philosophy, and obviously withdrawal symptoms, that physiological impact that the body and alcohol have together. And so by the time we're in the 9th version of DSM, so DSM-9 and the third ICD-9 and the third of DSM, they'd sort of realized that people didn't just suddenly arrive as being alcohol dependent, and they included this extra non-dependent diagnosis. So there was this sense that you could be non-dependent, and in DSM they call that abuse. In ICD, we called it harmful use. But just this sense of you could have a really unhelpful relationship, but it wasn't dependence. And then in 1976, there was a seminal work really by Edwards and Gross, which for the first time conceptualized a kind of clinical syndrome. And that was then influential in the next version of ICD-10 and DSM-4. And so this kind of allowed for the fact that there was a clustering of symptoms. Not everybody had the same thing, but you got a clustering of symptoms over a period of time, and they recurred. And that featured around that kind of increased salience towards alcohol. It became the more important thing. You perhaps lost control over it, and again, these physiological symptoms of both tolerance and withdrawal. They still included then, they also added a second dimension, which was this sense of harmful consequences of use. You didn't just have a diagnosis of alcohol dependence, but there was also consequences that were part of that. And actually, ICD and DSM really worked hard together, and there was a significant concordance between their two different diagnostic systems. Sadly, and this is why I've sort of slightly bored you with diagnostic systems, is that our current systems have slightly diverted again. And as Lucy was saying, all that does is kind of stir the pot of confusion of, is this really an entity if everybody comes up with a different kind of definition of it each time? And so in DSM-5, they did one thing that I thought was very helpful, which is they kind of made it into a spectrum disorder. They call it alcohol use disorder, which is the preferred term that I now use because it sounds less stigmatizing, it's broader, it allows for people to say, well, I might have one of those. I know I'm not dependent on alcohol, but I might have an alcohol use disorder. And there you can see the definition as they give it. But what they do is that they've had these 11 criteria, which again are much the same around salience, impaired control, physiological symptoms. And they say if you've got 2 of those, you're mild. If you've got 4 to 5, you're moderate. And if you're 6 or more, you're severe. But it says nothing about dependence, and it says nothing about addiction. And so for a lot of people, this is far too broad a categorization to really be helpful. Whereas ICD-11 has essentially stuck with what it did before, but has slightly rationalized it a bit, as you can see there. It said that there's a characteristic feature which is a strong internal drive to use alcohol, and then you have to have 2 or 3 of the impaired control, the increased priority of alcohol use, as Lucy was saying, just thinking about it all the time, and the physiological features. So you don't have to have all 3, you can have 2. So sadly, there isn't now a huge amount of concordance between the DSM-5 version and ICD-10. And for those of you who are Kappa nerds, the Kappa is actually only 0.36 between those 2 diagnoses, which is not good. Whereas if you take the moderate to severe DSM and compare it with ICD-11, it's actually, the Kappa is around 0.63. So it gets a bit better, but it's still not great. So we've sort of made things more confusing. So, where's my clicker? Here we go. So on this slide, I've just tried to summarize those sort of slight kind of differences in the diagnostics. You've got DSM-4 moving into DSM-5, which made it a spectrum, ICD-10 and 11. And then to add to that, there's this third dimension, which is actually how much alcohol are you using? Because none of the diagnostic systems actually put an amount on how much you're using. There's a kind of an assumption that you're drinking sufficiently to cause these problems, but dependence or any form of the categorization are based on the problems related from it, not on actually alcohol use. So there is this third dimension, which within our UK system, the English system, Public Health England now, OHID, the guidelines talk about lower risk drinking, which is less than 14 units of alcohol. increased risk drinking, which is up to 35 units for women, 50 for men, higher risk drinking, which is over those amounts. But as I said, there's no actual amount that is there for kind of where dependents start, because it's different for everyone. So, okay, there is some brief interaction. We were going to do this on VBox, but it got too complex. So you are going to have to shout out, okay, otherwise we're going to be here for a while. So, this is about how alcohol health literate are you. The guidelines are all based on units of alcohol. So what is a unit of alcohol? Okay, so question 1. Okay, this is a 175 or a medium glass of wine. If you were to buy it in a pub, it's a 12%, so it's kind of on the lower end these days. How many units of alcohol are in this glass of wine? 2, 3. Any advance? 2. Okay, 2.1. Well done. Okay, next one. This is notionally a pint of beer. Clearly the head on that is far too large and you'd send it back if you were served it. But if that was a pint of premium lager, 5.1%. Well done. Okay, it's actually 2.9, okay? And that's because of the premium thing going on. It's over 5%. It's 2.9. It's actually 2.89, but I rounded it up. So, this is a litre of Somerset cider. Liberal Democrat Somerset cider now, obviously. But it's 7%. How many units of alcohol in this? 6, 7, 8. Okay, there's a little clue coming up. There are 7 units of alcohol in that 1 litre of 7% cider. I know it's late. Okay, and finally, this is a standard bottle of vodka, so it's 700 mils, it's not a litre. How many units of alcohol are in this? 28? 28? 40. Was that 40 or 14? 1-4. Okay. 28. So I kind of rest my case on this, that here we have a bright, informed, interested group of people, and we have a really kind of significant, you know, our literacy is poor on this, okay? So how do you calculate alcohol units? So Sam, I got Huey in here just for you. So 1 unit, okay, is 8 grams or 10 mils of pure alcohol. So what? The way that we need to remember it in this country is essentially whatever the percentage is, there are that many units in a litre of the stuff, okay? So a 40% bottle of spirits, and in my world, all spirits are 40% because it makes the maths a lot easier until proven otherwise. 40% means you've got 40 units in a litre, 20 units in half a litre. And then that works all the way down to the fact that 1 unit is 25 mils. That's how we get to that, okay? And it's the one thing that's actually stayed the same since the units came out. Units haven't changed. What has changed is the strength of the alcohol we are drinking. So a glass of wine used to be 1 unit, but that was when wine was 8% and a glass was 125 mils. Okay, moving on because of time. So the reason this is really important is because when we then get to kind of both screening but also epidemiological studies of kind of trying to work out where our levels of alcohol harm are in the world and this country, we use that part of the WHO, that third part of their conceptualization, which is the alcohol use disorder identification test, and specifically the first 3 consumption questions. Now, this is what you should be asked when you go to your GP for your annual checks or your 40-year-old checks or whatever. It's what you should be asked every time you come into hospital. It is the gold standard. And so you can now do, and I won't get you to shout out, but you can now do your own audit score, which is how often do you have a drink containing alcohol, and you score yourself between 0 and 4. On those days that you drink, how many units do you drink, okay? And so again, if you only 1 or 2, that you get a 0 for that. If you drink 10 or more, you score 4. And how often had you had 6 or more units, or if you're a woman, or if a man, 8 or more units, on a single occasion in the last year? And so that should give you a score out of 12. And obviously that can't directly correlate to any diagnosis, but it could give you a little idea about what your relationship with alcohol may be. So, As I said, that comes out of these kind of three domains of the wider alcohol use disorders identification test, which looks at your levels of hazardous use. It has three dependent symptoms in there, and they talk about morning drinking, but that's really to try and get at those physiological symptoms. Do you kind of start to have kind of a need to drink in the morning in order to kind of prevent getting withdrawal symptoms, and then these harmful use, and the scores are there. But the reason I wanted to put that up and teach you about that was partly for your own literacy in this matter and for your friends, and it makes a good party game and upsets your husband when you go out and talk with friends about it. But essentially, the thing about this is that when you do these kind of, and this is the alcohol toolkit study, is when you do these kind of transnational surveys, it enables you to say, okay, so who is drinking at increased or higher risk levels? And what you can see here, they've been doing this since 2014, 4 times a year, and what you have here is the red curve. The darker curve is lower socioeconomic groups who drink slightly less, and the upper blue curve is the higher socioeconomic groups who drink slightly more. And then this was COVID lockdown, okay? And so this wasn't one of those surveys that said, now that you're in lockdown, are you drinking more alcohol? This asked exactly the same questions as they've been asking since 2014, so I think it's a really helpful survey. And then after a while, that kind of went down slightly, and we were slightly encouraged by that. And then 2021 happened, and this is the new normal. So actually, our prevalence of alcohol use in this country has significantly, of harmful use, has significantly gone up and seems to be staying up. Sadly, added to that is our kind of alcohol-specific deaths, so people who've died from deaths specifically related to alcohol, and there's a way of classifying those. And although these lines look much flatter, because they're based on standardized mortality rates, it's really quite hard to up the line a bit. And what you can see, first of all, was that in 2020, the alcohol-specific death rate was the highest it had ever been since records began, since they started recording this in 2001. And then between 2020 and 21, there was a further 7% increase, which takes it to 14.8 per 100,000 people are dying of alcohol-specific causes. And in total, that means that it's over 25% higher, the death rate from alcohol-specific causes in this country since 2019. The vast majority of those are from alcohol-related liver disease, and then alcohol dependence itself, it constitutes 12%, and a smaller number from accidental poisoning. So we really, really do have a problem, and I just want to spend the last bit of time thinking about how we really address it, because as you can see there, it's everywhere. Alcohol, it's a tiny molecule. It gets into every organ of the body, including the brain and the mind. It is essentially a poison. And yet it's the most commonly completely ignored in most clinical and research situations. And so how do we possibly start dealing with that? And so this is where we come back to complexity, really. And we're at the 3 levels we really need to think about how we implement evidence-based solutions. And I just want to run through some kind of up-to-date ways that we might think about that. So the first, at a macro level, at that society level, the jury's been and gone and kind of given the verdict now. Minimum unit pricing, in terms of being an effective strategy, is, there's significant evidence for it. The synthesis of all the evidence that has come out, despite COVID happening in the middle of this kind of intervention, which was just published in the last month, is really clear about the fact that minimum unit pricing in Scotland had a positive impact on health outcomes. It reduced the alcohol-related health inequalities, so the people in our society who have the greatest health burdens did better because of this policy. Alcohol-specific mortality reduced by 13% at the same time as the rest of the country was going up. So it's not as though we were trailing down anyway. It was going up, and this has brought it down. Hospital admissions reduced, and again, importantly, from an inequalities point of view, the largest reductions were seen in the most deprived areas. And the other ones there. There was a minimal impact on the consumption of those who are already with established alcohol dependence, and we can talk about that. But overall, as a population macro level thing, it's been a success. The second thing is regulation on the drinks industry. Massively important group, and a really good paper by colleagues in Sheffield and the Institute of Alcohol Studies back in 2018. And what you can see here is, you have the drinks industry telling you that actually what they want to encourage is responsible drinking. Yes, they don't want these intemperate drinkers. They just want temperate drinkers, thank you very much. And yet if you look here, and this doesn't really work, oh yes it does. So 60% of the population approximately don't drink anything. So the drinks industry don't make anything out of them from alcohol. 60% are drinking at, I would not call this moderate, oh yeah, I've got to put my slide on here, there you go. I'd call it lower risk, and I have words with them about this, but anyway. 59% of the population consume 23% of the alcohol and give the drinks industry 32% of their revenue. So those are your responsible temperate drinkers. The top 21%, 48 and 45, and the top 4%, 30% and 23%. So the drinks industry makes its profit from the people drinking at the highest level. That is where their profit comes from. They have a massive incentive to make people drink as much as possible, as frequently as possible, and to become as dependent on it as possible. That is a macro level policy that would actually be effective. So meso level, at the organizational level, what can we do? And just in the last, 6th of July, this month, the nice quality standards for alcohol have finally come out, and one of the things absolutely in there should be systematic screening of alcohol use. You're asked about your weight, you're asked about your smoking, you're asked about your blood pressure, why aren't you asked about your alcohol? Systematically and recording it. And as you can see there, the nice quality standards have said you use a validated alcohol questionnaire, so that one that we've just seen, the Audit C. The second thing is about actually accessing high quality treatment services. At the moment, and again this came out in the National Audit Office report into alcohol treatment services in February this year, only 82% of the proportion of people in England who are estimated to be alcohol dependent receive any form, 82% do not receive any form of treatment for that. So that gap in terms of need to what people are accessing is huge. And again, that is something that requires kind of funding in order to make that happen. And then if we think about the micro level in terms of evidence and interventions, and this is the BAP, so we need to offer, evidence-based pharmacological and psychological treatments for the group of people who are alcohol dependent, moderately to severe alcohol dependent, for those for whom actually that would be indicated. And again, the nice quality standards, I'm really pleased to say, has managed to get that in there. The first of which is, if you go into acute alcohol withdrawal in a hospital, you need to be assessed and monitored following locally specified protocols. Good, start. And then the second one here, adults with moderate or severe alcohol dependence are offered a psychological and, if appropriate, pharmacological intervention to prevent relapse. So relapse prevention medications following a successful unplanned withdrawal in hospital. And yet at the moment, of all the people who are moderately to severe alcohol dependent who have a withdrawal, approximately 10% are offered some form of pharmacological intervention. So again, we have the pharmacological interventions, people are just not offered them. So we could start implementing the treatments that we already have. And so if we want to bring this together, how do we minimize the number of people who develop harms from drinking by improving the access to, experience of, and outcomes from evidence-based interventions in order to make them more effective? Evidence-based pharmacological interventions are vital in helping the most severely ill, but I would contend that there are many barriers that people need to get through, as Lucy was saying, if they have a chance of accessing them, and those barriers are just as important for us to address. And so I come back to this sort of idea of we have these different levels at which we look at things. We need to think about the drivers of societal norms, the non-specialist management, and then specialist management, and that is where those evidence-based pharmacological and psychological interventions sit. But we've got a lot to do before we get there. And just to bring it all together in these last couple of slides, 4 slides, is about the fact that what are those drivers for societal norms and, stigma around it? And as I kind of pointed out, I hope, history, we bring a lot of baggage with us around alcohol. The drinks industry versus the public health influence on government and government policy. The lack of powerful advocacy groups, and this is why it's great that we have Soberistas and other kind of recovery groups now starting to be able to, thanks to social media and the internet, to be able to actually reach people who were not reachable before. And also kind of celebrity and other influences. So again, I'm really delighted that the BAP has given its Public Impact Award this year to Johnny Ashton and Will Young for their documentary about Rupert, Will's brother, who died. Again, it's these sorts of things that we've got, you know, that help bring this to the fore. At a meso level, then, it's about thinking about prevention as priority across the healthcare systems. In my NHS England role, I fit and sit within the prevention team, and yet prevention at the moment, it's uncertain where that fits in the new NHS. So watch this space. But then we also need to think about the micro, and for all of these, I put in the, you know, a patient or something that has been said to me not once, but probably dozens, if not hundreds of times over the years. And for the individual person, that's often, please don't write this in my notes, I don't want it to go on my record. And, you know, we have that tension that is there. So, what are the societal norms? And how can we affect them? So we've got stuff around price, taxation, availability, the public health, you know, kind of evidence for this is overwhelming, versus advertising and media influences, as Lucy was talking about. And this whole idea of dividing people into responsible versus irresponsible, temperate versus intemperate, good versus bad, one of us, one of them. And it's all terribly, terribly insidious. I think at a meso level, and this is something that has preoccupied me for the last 20 years. I've done little studies, and in fact, one of my students 20 years ago got a BAP poster prize looking at actually how people's own drinking behavior, health professionals, and the attitude that has on people's when they come in and you know, and how they treat people. And this was just in our one of our local Facebook pages of a health professional somewhere near me who said, well, it's not really a party unless you get off your face, is it? So, you know, you have those attitudes that are then kind of being influencing our healthcare staff. Where do we get the non-specialist management? This is my day-to-day role as a clinician. We need funded integrated healthcare pathways. We've just seen that I showed you the data that 78% of the highest number of people ever now to die of alcohol-specific causes was due to alcohol-related liver disease. And yet you come into hospital and you see a hepatologist and they tell you to go somewhere else for your alcohol. Where is the alcohol-related pathway? Where is the pathway for the patient who comes in suicidal crisis, who can't get through to mental health services because this is all due to their drinking? Where are the pathways for those? And this, sadly, is something that I frequently hear, and a very specific one recently. The mental health team, won't treat my PTSD until I stop drinking, but I am drinking to manage my PTSD. So, and finally then, in terms of the specialist management, we must prioritise research, and I'm really pleased that there's now an addictions life sciences kind of call for that. And it needs to be research that actually brings us to kind of what patients want and need. We need provision of proper high-quality specialist services, and we need also that sideways support for recovery communities, which I've talked less about today, but are absolutely essential for the ongoing kind of, you know, care and support and encouragement of people. At that health professional level, we need, you know, addictions have got to be the place to be. You've got to make it high quality and to have a good sort of training pathway. And then within that, that is where our evidence-based pharmacological and psychological treatments can really, really be effective. But as I said, I would contend they can't be effective until these other things are really all part of that same narrative. So what can I do? What can we all do? Number one, become health literate. Alcohol health literates, know your own number and monitor it if it's helpful. You know, every so often it might be a good idea to think, actually, how much have I drunk this week, this month? Do things like dry January as a kind of test to see what your relationship with alcohol is. Accept and encourage people who are choosing to be alcohol-free. As Lucy said, don't feel sorry for them. Say, yo, well done you. That's amazing, fabulous. Be mindful of the corporate tactics to get you to drink more. be an ally and challenge stigmatizing language about addicts and alcoholics unless people self-identify as such. I will have people come to my clinic who say, I'm an alcoholic. That's fine. That is helpful for them. If people do so, that's good. But don't go in and assume people might find that a helpful label. Thank you very much. And if you're uncertain who is in control, you or the alcohol, seek help. Thank you very much.
Good. Thank you very much, Julia and Lucy. And it's now time for questions. We have a roving microphone, so please wait for the microphone to come to you before you ask your question. So, who'd like to start? There was someone there. Wait for the microphone.
Can you put your hand? You can't see yet.
Yep.
Just a question to Julia. I know you talk about part and parcel of the kind of personal reasons or individual reasons as to why people consume more alcohol or become heavy drinkers would be childhood adversity or childhood adverse experiences. What's the latest kind of evidence to say, or actually, sorry, let me reframe that. What kind of childhood adversity predisposes you most to being a heavy drinker?
I think it's, my understanding of the evidence as it is now is it's more about the weight of your childhood experiences, if you see what I mean. So I think it's about your number of adverse childhood experiences rather than any specific one or more. But again, I think that has an interaction with the individual and the other support that they have there. And, you know, there's long-standing evidence around attachment theory that, you know, to have one secure attachment actually gives you a significant amount of protection for things. So I think, as always, it's complicated, but my understanding about the adverse childhood experiences, it's very much about the weight of those experiences rather than the type.
Okay. In the front, sorry.
Oh, there's one there, David, already. With a microphone.
Okay, I'm sorry, yes. And then...
Yes, right, yes, right. Thank you both for those two very inspiring talks, and this is a question for both. So we know that about 30% of the people are high-risk drinker, 4% of which are harmful, which means whatever professional service, if those people all seek medical advice, will be overloaded. So I'm asking whether, to what extent is non-professional help effective? So basically it's perhaps more of an experience based for Lucy, and do we have also scientifically quantified that effect from the clinical side? Thank you very much.
Yeah, thank you for that. Actually, University of Southampton did do a research study into Soberistas a few years ago in 2015 to find out who was using it, and a bit of that was kind of qualitative about whether it was effective or not, wasn't it? And anecdotally, it's very effective. People stay on Soberistas because they feel as if they can talk openly without being judged. The anonymity is very important. So what we found from the research study that Julia's team did in 2015 was that 2/3 of the people on Soberistas had had an alcohol problem for more than 10 years. And I think it was the same, two-thirds, wasn't it, who'd never asked for help from anyone else, or never kind of spoken openly about having an alcohol problem before they'd come onto the Soberistas website. So it kind of showed that there was this huge number of people drinking secretly because of shame, because of fear of being, you know, social services becoming involved, etc., who wouldn't have gone and asked for help from anyone else. And it works, Soberistas, in the same way that AA works for some people, in that it's mutual support. So it's people who are mutual aid, people who understand and who can speak to you, who aren't going to judge you, and who will support you because they know what you're going through. That's basically, it's the same model, but it's without the kind of 12-step and without the religious component, but it definitely works, and I think one of the major reasons it works is because it circumvents those very big real barriers to help that exist for an awful lot of people.
Got your Alistair Campbell
Thank
quote.
you. Yeah.
Gonna give it? With the mums net.
Yeah, so Alistair Campbell, who has done a lot of work, who works a lot with sort of mental health charities, he was quite he was a significant part really of us getting the word out about Soberistas in the first instance, and he coined Soberistas a mum's net for worried binge drinkers. So that kind of, yeah, that's a really good description of it, just because it gives it sort of explains, I think, the community aspect of it, that kind of togetherness that really is a big part of why it works.
Thank you. So we have someone over there. Yeah.
I'm a trainee in psychiatry, which is the context for the question. I guess I wonder if you have any advice on how to communicate with teams when you do get the response, no, we won't accept this referral until this person stops drinking. Any like phrases or lines to put in email just to keep the conversation going and make it clear that that shouldn't be the reason they don't accept a referral?
Thank you. I think that's really important. I think trainees are in a really challenging situation because I think, you know, they coming through and seeing this is wrong, and then their elders are not necessarily betters, are kind of saying, well, this is the way it is. So I think there's a number of things, the first of which is the IAP, the increasing access to psychological therapies guidance is now really quite clear that you should not kind of exclude people because of that. It should have been out by now. There are some new alcohol guidelines coming through from PHE, which should have been out 18 months ago, and the next date is September. But in that, it's really quite clear about that, you know, there's a whole chapter on this, and it will be very, very helpful. It's just frustrating it's not out yet. The one thing that I tried was to say, well, at what level do they need to be drinking in order to come to your service, and was told less than 14 units of alcohol a week. And I said, does that apply to your staff too? And then I got bounced to a manager and we got somewhere. So I think there is that, and for me, that's where it comes to this sort of the complexity of challenging some of those norms. Now, you're a patient, you have to be drinking less than this. And you think, well, but why? And I think the other thing is about, you know, if people have been able to come to appointments on time and engage with things, they are able to engage with psychological therapies. And I think sometimes you get stuck with an older cohort of people who have this very kind of blinded, I would say, view that, you know, you have to be perfectly everything in order to take it, in which case you probably don't need the psychological therapy. So I think it's those sorts of things. I think some of those challenges about, so what's the difference why are there different rules for the patients than there are for the staff, kind of can sometimes get under some of that skin.
Thank you. Akeem?
Yeah, thanks for a great talk. Really, really enjoyed it. My question relates to research on ethnic minorities. So I'm aware of the problematic drinking among Punjabi Sikhs, but I'm also aware of, like, I'm from Nigeria, and I remember in Nigeria, the binge drinking pattern was different. People tended to drink, and they were almost trained to become tolerant. So if you drank and you fell over, that was frowned upon. But you had veterans who were basically encouraged to drink, to hold your liquor, and so tolerant drinking was encouraged. Because I remember seeing people in medical school that had an alcohol dependence. So I'm wondering if there's been any of that kind of research done in different ethnic groups. I'll also be interested in the ethnic minorities in Soberistas. Thank you.
Well, I mean, the ethnic minorities in Soberistas is a good question and not one that we actually have ascertained. So we haven't taken any data at all about the demographic of our members other than age, gender, and I think that's it. Age and gender. Purely because it's a completely anonymous site. So the model has always been not to ask for any data. Whether we might do that at some point in the future. One thing that I would say is that we have just applied a few months ago for charity status, and which we really need. And if we get our charity status, and we're hoping through that to increase our funding sources, one thing we were really keen to do with that extra funding is to invest a lot of it in research that will help us all understand the problem of drinking, who it affects, and how we can help people better. So I would say it's something that we would look at doing with funding. But
And from honestly, Akim, it's such a challenging problem. I think, you know, there's a really good peer-led recovery lobbying organisation actually called Back In, which is led out by someone called Sohan Sahota and David William in Leicester. And they have set it up exactly for this, to try and actually have the experience of people from minoritized groups properly represented in recovery communities. And I remember when I phoned Sohan, because I was desperately trying to kind of increase our diversity in terms of one of the projects that I was doing with Sam, actually, about substance, alcohol, and behavioural addictions in people with autism. And I spoke to Sohan. He said, "Yeah, but I can only tell you about the South Indian. You need David because he has a better idea of the Afro-Caribbean, and that will be different again." So again, we have this thing of, I think, moving away from, you know, the BAME label, that actually underneath that there is just such a massively different set of kind of experiences for people. And we have a large Sikh community in Southampton, and for years we've been trying to get a Sikh worker within our alcohol and drug services, because again there's just many more layers of stigma for coming. And as you say, people kind of, you know, it being a bit of a not being a man to not hold your drink, and therefore a massive enculturation to get to a state where you can actually hold your drink substantially, and you can't challenge those from outside of that community. So I think it's yet another ocean of work that needs doing in this area.
We have someone there, and then if you could take the mic up to the person there with her hand raised. But here, yeah.
Thank you. A question for Julia, just picking up on your response to the trainee psychiatrist question over there, and you said...
Sorry, could you speak up?
Sorry. There's a question for Julia, picking up on your response to the trainee psychiatrist question over there about people not being able to access mental health services if they're drinking. And a very fair point that if you're able to engage and attend appointments, then you should be able to access services. But what about do you have any suggestions on how to best to support patients who don't manage to attend their appointments because of the alcohol-related brain damage effects, and they just simply forget appointments?
Yep. So yes, alcohol-related brain damage, or sometimes called alcohol-related brain injury, or alcohol-related cognitive impairment, seems to be the three umbrella terms that are covering the same thing. And it's an increasing problem. And I think, you know, it's not just mental health services, but also patients don't meet their hepatology appointments because they don't open the brown envelope. And, you know, and it has a problem with executive function. Again, Liverpool and Glasgow have led the way in terms of services for this, and it comes back to my point, which was we need proper services, is that people come in to hospital, wherever it is, you know, you identified with alcohol-related brain injury, and just for those who are not aware of it, these aren't kind of dementing patients. These are patients who you could have a perfectly normal conversation with, but actually underpinning that, the infrastructure of their executive function is not there. So a classic example of this from a couple of years ago, I had a woman being discharged from hospital who was being told, I was being told by the other medics, that actually she was going home to her fiancé, and I was saying, so is that the fiancé who she's got an injunction out against for the last 2 years because he's been violent towards her? And they went, oh, she didn't mention that. I said, well, no, because she still thinks she's with that fiancé and she'd forgotten about the injunction. So people can appear, so this idea of confabulation that people have heard of, it's all about pathways. And I think the awareness is being raised. Places like Glasgow and Liverpool have done some really good work in showing that it's possible. In some areas, they actually team up with their head injury places, because the two are not mutually exclusive, funnily enough, and have done some nice pathways there. But again, it's a real postcode lottery, depending on kind of goodwill in more than one of the services to make it all knit together. Thank you, yeah.
So at the back.
Oh yeah, that it is working. Thank you both for two really interesting talks. I just am curious, really, both of your responses on this. So I can really see the benefit of kind of the anonymity side. Have I got an echo, or is it just me?
Sorry?
We can hear you fine.
Oh, okay, right. The anonymity, and I think that that's crucial for getting people into whatever support is working best for them. But I suppose thinking of the flip side, I'd be really interested in both of your views on what we can do to kind of almost remove that need for anonymity in the first place, because if it does feel like it's something that needs to be closeted away, then you almost get this like us and them kind of thing, like of people feeling like safe in kind of recovery communities versus out there in the real world. So I'd be really interested in that, and also whether you think that the kind of stigma side of things might be changing generationally, and if that's something that we're seeing any shifts in. So thank you.
Yeah, thanks for that. I think social media's gone a long way in the last 10 years to sort of breaking down the stigma and opening up a conversation, lots of conversations about kind of what alcohol dependency is, what an alcohol problem looks like. So there's somebody in America, a woman on social media, Jolene Park, who's really kind of done a lot in this area. She coined the phrase grey area drinking. So that's a really helpful term that resonates with lots of people, I think, just that they wouldn't define themselves as an alcoholic or even, sort of hazardous drinker, but definitely have a problem with alcohol, and they could sort of fall somewhere in the middle. So those hundreds of thousands of people on social media, I don't know how many there are, but there are just so many now, kind of influencers, sober influencers, who are so positive and who've given a really good kind of, they've reframed it completely, so it's not so much about being sort of, all cloak and dagger kind of I'm an alcoholic and shuffling about in a church hall and hoping nobody sees you, but actually just being really, talking about it in a really open and honest way, and that's really gone a long way, I think, to breaking down the stigma.
I agree, and in fact, something that we came across in the research, which we did with Soberistas, which I thought was a really important thing, is we think about the ambivalence that is there when in any addiction. If you have a relationship with something that is all-powerful, it's like a coercive, controlling relationship, isn't it? And therefore, actually, when you're wishing to leave that relationship, there is the ambivalence of what's the pull that keeps you, what's the pull that... And, at any one moment, both of those things will be there. And so it's perhaps not surprising that there is this need, perhaps, and we came up with, I think the term kind of came up around Soberistas, but it's of lurking, like people do in chat sites, lurking, which kind of doesn't sound great, but actually for some people can be really helpful. It's, grey area drinking now. Do I have a problem? I don't know. I'll go and I don't want to sign up, and I don't want to kind of post something in a chat because I'm not sure, but I'll just hang around and see. And I think that's the great advantage of particularly the web-based things and the anonymity that it gives, is that it's not that you're necessarily ashamed about it for anyone else. You've got that internal kind of battle that you need to overcome first before you'll even take a step. And so to walk into an AA meeting, and I'm not knocking it, they're absolutely amazing for the people for whom they've been helpful, but it takes a huge bit of courage to walk into a room of people that you don't know, to be able to say, I think I'm here because I think I'm alcoholic. And I just think that's a huge barrier. And so consequently, anything that brings that barrier down a bit, and online AA meetings have also really helped with that, because you can now kind of come on, you don't have to put your camera on. So I think it's not so much about the wider stigma, although that's still very much there and embedded in our health services particularly, but I think it's as much that internal self-stigma, the perceived stigma, and all of those things that stop people from feeling that they can and they should and they want to do something.
Thank you. We've got time for 2 or 3 more questions. So Holly. Oh, sorry, Holly, and then gentleman at the back. But Holly, you go first, because you got the microphone first.
Sorry, just touching on stigma again. I was just wondering, is there much support for families who are caring for someone with an alcohol problem or who've lost someone from an alcohol problem? And also, is there much support for clinicians? Because I would imagine it could be emotionally quite a challenging role.
Thank you.
Do you know about carers?
No, not really. There's very little. Again, you've got some local charities that do some really good work. You've got Al-Anon, which is the sort of carer version for Alcoholics Anonymous, which again takes a particular model, which is quite challenging, I think, for some people. And there's again, it's a massively under kind of represented area, and this is why I think Will Young's kind of documentary with Johnny Ashton was so powerful, because it just showed that you as the family were kind of left, even with a family with massive resources, were still just kind of left to deal with it and had very little. So no, that's yet another ocean of awfulness. For healthcare staff, I think you need to reframe it, Holly, that it's a really distressing thing to work with. I think it's the most satisfying branch of medicine.
Great. Right at the back.
I just heard at the end now of the talk that there's also an issue with co-addiction. So it's in my family also, and it's a very complicated story and lots of dynamics. So it's kind of, just today I had a talk to a family member about this issue with the clinic, and you're far away. It's just, you end up in a situation, just to paraphrase it, like you are in a co-victim situation. So the one who is struggling with it has always the card of, oh, I'm sick, and the others are the bad guys, and vice versa. So that's a huge, huge sea of ugliness, I can only say. The other issue is just to mention this so it goes across the board, is when I see BAP, the British Association for Psychopharmacology, do they have a seat at the table in the government to say, because there's a lot of lobbying. Is there lobbying coming from BAP, for example? I'm a member of BAP, and I would be pleased to hear that they do lobbying, because it's so hard. Because all these industries, they have loads of money, so they get the best psychologists, they get the best whoever, just to do all those advertising. So they're very sophisticated, and they know where to go. Thank you.
From the BAP point of view, we don't have a seat at the table as regards kind of lobbying government. We don't. But we are a kind of registered consultee for practically everything that comes out relating to mental health problems. So when there's a thought about whether there should be a guideline on something, we feed into that. And when a draft guideline is produced, we feed into it. And when a guideline is being revised, we feed into that as well. But we don't have a direct lobbying stream to our work. Yeah.
I think there was another question.
Yeah. Any more questions? Oh, another one. Oh, sorry. Yeah, we'll do people who haven't asked the question first. So, yeah. And then we'll make this the last question. I think that's probably best. So, if you just wait for the microphone. Sorry. Yeah, it's
I'll be super quick. I just really want to ask about, I'm looking at the online sober communities in particular, and I think what you've done, Lucy, was definitely pioneering and set the scene way before many other communities have come online. But now we do have the sober movement, we have so many online sober communities. So what's that journey going to be like? How can we get it that when a woman who is worried about her drinking and doesn't suspect she is an alcoholic or has an alcohol use disorder, how do we get to the point where a GP will be referring them to digital online places? Because at the minute, just like you said yourself, Julia, someone came to you and told you about Soberistas. And I'm surrounded by daily I'm seeing women at all stages of their relationship with alcohol change and becoming sober, and the stigma isn't there. And they are thriving without having alcohol in their day-to-day lives. And it is solely because of the groups that they've come across online. Now, there is a barrier. There's a digital barrier there, but there's also a financial barrier. But how do we get to the point where, in the future, we would hope GPs would be saying to them, as part of a preventative package, here are some digital platforms for you to start.
Lucy.
Yeah, well, it's a question that I think brings together loads of points that have been made tonight, so it's a really good question to end on. But what Julia was saying about the different levels of society, so the micro and the meso and the macro, I think that's partly the answer to your question. So we have lots of people coming on to Soberistas who are kind of completely flawed, don't want to talk about their alcohol problem, really bothered about the stigma, don't want to sort of put their head above the parapet. And then as they become sober and they grow in confidence and they become really proud of the decision to not drink anymore, then they quite often tell their doctor about Soberistas. And so more and more we're finding then that we've got this nice micro feeding into that kind of sort of the medical professions knowledge base about help out there. So they're not just signposting people to AA anymore. They're finding out about places like Soberistas online, and they are then recommending them. Julia contacted me, didn't you, years ago when we first set Soberistas up, and has been we've been in touch with lots of hospitals, lots of alcohol support units over the years now who've got leaflets about Soberistas who they hand out to people. So it is slowly kind of becoming, it feeds into, sort of medical knowledge, I think, because of the people who are finding success in those online communities. So that's a really nice kind of reverse of the situation, I think, where it's coming from the grassroots and going up.